Hello, everyone. Welcome to the Functional Measures for Assessing and Managing People with Chronic Pain webinar. We're glad you're here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is made possible through the support of the Community Gaming Grant Program through the BC government, as well as donations and memberships to CIRPD. As I mentioned, my name's Tanya, and I'll be moderating the webinar and handling the Q&A session today. And our presenter is Dr. Jane Ballantyne. Dr. Ballantyne trained in anesthesia in Oxford, England, before moving to the Massachusetts General Hospital, Harvard University in Boston in 1990. She became chief of the Division of Pain Medicine at MGH in 1999, and she moved to the University of Washington in 2011 as the UW Medicine Professor of Anesthesiology and Pain Medicine. She has editorial roles in several leading journals and textbooks and is widely published author and researcher. We're glad to have you with us today, Jane. I'll hand it over to you.
Thank you, Tanya. Good morning, everyone. This presentation that I'm giving today is going to focus on functional measures for assessing and managing people with chronic pain, and it's going to offer alternatives to simply using a pain scale. This talk is going to be divided into two parts. The first part, I'm going to talk about what are the reasons that the pain scale is actually a poor guide for chronic pain care. In the second part, I'm going to talk about what's the practical measures that can be used as an alternative to simply using the pain scale. The suggestion is not that the pain scale should be completely abandoned, but that it should be considered a secondary measure of pain outcomes when pain is chronic, rather than a primary measure. So the whole idea of using a scale, and to follow on the idea of using a scale as a basis for titrating drugs, really began not that long ago with the WH stepladder, which was proposed as a way of measuring and treating cancer pain. So this stepladder is probably familiar to a lot of people who treat pain, and it's been used actually beyond the suggestion that it should be for cancer pain as a tool for chronic pain and even for acute pain. In many senses, it's a misuse of its original intention. So what this suggested was that the first step of analgesia would be non-opioid analgesics and possibly the addition of adjuvant therapies. The second step would be the same thing with the addition of weak opioid analgesics. And the third step would be progression to potent opioid analgesics. The underlying principle of the WH stepladder was that medications would be used in an incremental fashion in accordance with the patient's reported pain intensity. We got so used to that principle that it's hard to remember that we didn't really think about pain in those terms not so long ago. The original stepladder also stated that analgesics should be given at regular intervals rather than as needed. And it stated that doses should be escalated with the aim of relieving as much pain as possible. About this time, people began to put forward the suggestion that not treating pain of high intensity or not treating a patient's report of high intensity pain was actually unethical. This comes from an article by Wanzer et al. In the New England Journal of Medicine in 1989. The proper dose of pain medication is the dose that's sufficient to relieve pain and suffering. To allow a patient to experience unbearable pain or suffering is unethical medical practice. following on this were several initiatives to introduce the idea of treating pain intensity or titrating particularly opioids to pain intensity. The American Pain Society was probably the first to suggest that the pain score should be used as a fifth vital sign. The American Pain Society and American Academy of Pain Medicine put forward the idea that opioids are an appropriate part of chronic non-cancer pain care, whereas before the 1990s, opiates were generally considered either not effective or too dangerous, that is, too high an incidence of addiction to be used for chronic pain. Not that they weren't used at all, but there was a general sort of teaching that they were not appropriate for the treatment of chronic pain before the 1990s. Then the JCAHO, which is the US Joint Commission for the Accreditation of Hospitals, actually introduced a mandate that pain should be measured and treated, and the Veterans Administration introduced a similar mandate. The US Institute of Medicine report of 2011, which you may have heard of, it's called the Blueprint, identified how prevalent undertreated pain is. So what I have written recently and have begun to explore as an idea is that the pain scale is actually a poor guide, particularly when managing chronic pain. We've got very used to it. We use it as a tool commonly, but maybe we should reconsider whether it should be used as a primary measure of chronic pain. I think the problems with pain intensity as a primary measure for chronic pain are the following. First of all, it leads to a wrong understanding of what chronic pain actually is. Secondly, it's the wrong goal for outcome of chronic pain treatment. And thirdly, it tends to end up with treating the wrong patients, particularly the wrong patients with strong analgesics. So I'll just explore those three ideas. Chronic pain is not simple. Chronic pain is very rarely simply nociception. In fact, particularly psychosocial factors play a very important role in chronic pain, to the extent that they're probably override any sort of simple nociceptive factors. In fact, we know that if we take two patients with exactly the same pathology, their pain experience is likely to be completely different depending on psychosocial modifiers. This is a schematic representation of the biopsychosocial model of chronic disease, but it applies very well to chronic pain. And I've emphasized that in the case of chronic pain, it's the psychosocial modifiers that make this progression from disease to illness and very much influence the clinical outcome of chronic pain. There are obviously biological, psychological predispositions and environmental factors that affect the progression as well and the outcome, but psychosocial modifiers are very important in the case of chronic pain. Secondly, chronic pain progression is neither linear nor predictable. That distinguishes chronic pain from acute pain or pain at the end of life. Terminal cancer pain can be expected to gradually worsen. Acute pain can be expected to gradually and predictably improve. But the level of chronic pain the patient experiences at any time is a function of multiple factors, and they include the mood, even the weather, the ability to be distracted, the patient's perceived response to their treatment, maybe to a sense of hopelessness. In fact, hopelessness and the unending nature of chronic pain is very closely related to the suffering associated with chronic pain. Social circumstances have a huge influence, and the disease progression obviously affects chronic pain, but is not predictable. So the underlying thing is that chronic pain actually fluctuates. It's also the way chronic pain patients communicate much more than simply nociception or simply pain. It reflects a moment in time. So when a chronic pain patient is asked to come up with a pain score, it may be very difficult for them actually, because their pain it's a total life experience, not just a moment in time. So coming up with a scale for a moment of time is really difficult. It's imbued with meaning. The current circumstances will probably determine the pain level of that moment. It may be the way a patient's trying to communicate overall suffering. Maybe they're trying to tell their provider something different from what we generally take to mean when a pain scale is given to us, for example, in the case of acute pain. And it may also be a way of communicating a need for medication. So the second broad reason that we're suggesting that a pain score is not the best outcome for outcome measurement for chronic pain is that a reduction in pain intensity may actually be the wrong goal. And one of the important reasons that it may not be the right goal is that not many medical treatments actually do reduce pain intensity very much. Opioid therapy reduces pain more than any other treatment, more than any other pharmacological treatment or any other behavioral physical treatment. It can reduce pain by as much as 30%, but only when you first start using it. With time, as we all know, opiates do not have such good analgesic efficacy as they do when you first start using them. Some of the other commonly used pain medications, such as the antidepressants, the gabapentinoids, only reduce pain by at maximum 1 point in a 0 to 10 scale. And behavioral treatments and pain rehabilitation programs reduce pain very little. Pain rehabilitation programs are the most successful. So chronic pain intensity scores are actually a poor guide to treatment response. Although when you give some of these adjunctive treatments, pain relief may be interpreted as due to that medication, there have been plenty of studies that now show that, for example, the gabapentinoid effect is only partly mediated by pain reduction. It's largely mediated, in fact, by sleep improvement. Likewise, the antidepressants, the pain relief is actually largely mediated by the antidepressant effect itself. So finally, the issue of the goal of pain treatment or chronic pain treatment. If your goal is simply to reduce pain intensity, the achievement of that may actually come at the expense of more enduring goals. Improvements in function and quality of life are probably much better primary goals for chronic pain treatment. Aggressive attempts to lower pain intensity using opioids can actually worsen function and quality of life. Improvements in function and quality of life can have a secondary benefit, reducing pain intensity despite no change in nociception. So without using any drugs at all, improvements in function particularly can actually have a secondary effect of improving pain scores or pain intensity. coping, developing coping skills, acceptance, which can be achieved through acceptance treatments, but also through good counseling, and functional improvement have been shown to dramatically reduce the suffering that's associated with pain's intensity. And suffering has more to do with pain's meaning than its intensity. So for a chronic pain patient, the meaning of the pain, the relentlessness of it, is actually the root cause of the suffering, not so much the pain intensity. In fact, pain's intensity, or the intensity due to nociceptive component of chronic pain, generally tends to be far lower than for acute pain or pain at the end of life, particularly cancer pain at the end of life. So the wrong patients. Assumptions were made that the pain scale was a good monitor for pain treatment on the basis of the success of that approach for acute and subacute pain. But when pain is chronic, the pain diagnosis is not always clear. And as I've already said, the socio-psychological drivers often take precedence over the biologic. One very important factor is that people with chronic pain who report very high pain scores tend to be people who manage pain and manage pain treatments, particularly opioid treatments, with great difficulty. They're often overwhelmed. They often have comorbidities that can worsen with opiates, such as post-traumatic stress disorder, mental health diagnoses, and substance use disorder. And that has actually been very well documented recently. There are now multiple studies that show this phenomenon of what we've termed adverse selection, which is that people who tend to use opiates for long periods of time, and particularly those who tend to get to very high doses of opiates, tend to be people with very high risk of both the development of chronic pain and the development of substance use disorders. After trauma, anxiety predicts pain better than pain predicts anxiety. So the role of anxiety is a very key factor in how people recover from chronic pain. So what this is really about, the idea that we have not been successful in overcoming chronic pain when we use the pain score as our primary measure, is that the titrate to effect principle, the principle that was first laid out with the WHO stepladder, that is, use medication at whatever dose is necessary in order to reduce the pain score, has had a disastrous effect on our management of chronic pain. So we now see a lot of patients treated with opiates who are not actually getting very good pain relief and who are experiencing all the adverse effects of prolonged opioid treatment. It's the titration to effect principle has tended to lead to continued dose escalation and high doses without pain intensity improvement. In other words, it's chasing an impossible goal. Simply reducing pain intensity may not improve functional quality of life. Pain intensity alone is not a reliable guide for treatment. Higher opioid doses are associated with more underlying risk factors and this phenomenon of adverse selection, and with higher rates of adverse events. Futile attempts to reduce pain intensity using opioids has led to iatrogenic injury for treated patients and for the population at large. And we know from a lot of efforts that have been made to look at evidence to support chronic opioid treatment. We've just been through the process of developing the CDC, Centers for Disease Control guidelines, and done yet another complete culling of the medical literature to find what evidence supports it and what evidence refutes chronic opioid therapy. And as has been found before, the evidence that supports prolonged efficacy from opiates is virtually completely lacking. There aren't studies that show long-term efficacy for opiates, but the evidence of harm from long-term opiate use is substantial. So particularly at higher doses. So higher doses have been associated with higher rates of overdose and death, less likelihood of being able to wean if necessary. So when young women become pregnant or when people go into hospital for surgery or suffer trauma, it's very hard to manage their pain. There are higher rates of mental health and substance use disorder. And so this is a population that's much less able to control their usage, which is probably a very strong reason that they do tend to get into trouble with opiates and lose control and sometimes overdose. Higher rates of falls and fractures in the elderly particularly, less likelihood of returning to functional work, higher rates of endocrinopathy affecting fertility, libido and drive, and higher rates of immune dysfunction. So these are some of the studies that show consistently that the higher the dose, the higher the death rate. These are the studies, there are plenty of them now, there are even more than I have shown here, that show that people who are treated, particularly treated early on after injury with opioids, are far less likely to get back to work ever than people who are not treated with opiates. This is an interesting study that shows, if you look at these graphs, maybe in your own time, if you have a chance to look at them, it said that when the higher doses of opiates are used in both physical health domains and mental health domains, function actually decreases rather than improves. At lower doses, you see some improvement in function. This is some of the adverse selection literature, the idea that patients self-select into the higher doses and the less effective treatments according to their underlying risk factors. So in conclusion for this section, striving to eliminate or minimize chronic pain through opioid therapy has led to iatrogenic injury of patients and the general population. The root problem may not be opioid risks or efficacy, but the focus on reducing pain intensity instead of functional measures. Our duty to patients is not to reduce pain intensity, but to improve their quality of life. And that's a really important point, because I think we have been, as I showed at the beginning of this talk, we have become so used to the idea that if someone has a high pain intensity, we must reduce it. And I think we have to rethink that if we're going to overcome our problem with reacting to all pain with the only treatment that reduces pain immediately, and that is with opioids. So the second part of this talk, I'm going to talk about a better way to measure and treat chronic pain. So some practical alternatives to simply measuring a pain intensity and responding to a pain intensity. Underlying all this is that I think we have newer principles of chronic pain management. The IOM, the Institute of Medicine, has actually said that we need a cultural transformation in the way we assess and manage pain, because despite all our efforts and despite the popularization of opioids for the treatment of chronic pain, and despite much effort in the pharmaceutical industry to come up with new drugs to treat pain, and despite new technologies, new stimulation techniques to treat pain, the problem of chronic pain has just got worse and not better. And so I would propose that the cultural transformation that we need is actually a demedicalization, particularly of the most common pain conditions. So when I was taught, I followed and was taught to follow the pathway on the left of this figure. We would investigate. We'd often use MRIs, EMGs to try and find pathology. We'd use interventions if possible, so surgery or injections. If we didn't achieve success with interventions, we'd use mild analgesics, and if we didn't achieve success with mild analgesics, we'd use strong analgesics. The new pathway is to recognize the complexity of chronic pain and to measure not just the pain intensity, but to measure all the other factors that are probably more important contributors to the chronic pain, that is mood, anxiety state, trauma, childhood trauma. To take a holistic approach, to take a whole mind-body approach to the individual, not just focused on pain intensity. Primary treatment is to counsel, encourage self-help, self-management, and to activate patients to be engaged in the process of improving pain with your help, but certainly the component of their active engagement in improvement is terribly important. And then, if necessary, use mild analgesics. And you'll notice that strong analgesics don't even figure on the right side of this figure, which is for common chronic pain conditions. So this actually is a patient who presents with back pain. General principles are that chronic pain is never simple, that measurement tools can be used as a means of understanding the scope of the problem, that primary treatments for chronic pain are motivation, activation, and counseling, and secondary treatments are low-risk analgesics, psych meds for depression, anxiety, PTSD, and psychosis, if they're identified and if they're appropriate. They can often make a huge difference to patients with chronic pain. In fact, untreated depression or anxiety is going to hamper all efforts to improve chronic pain. This is a tool we use at the University of Washington. It's very useful because it incorporates the measures of depression, anxiety, patient satisfaction, pain interference. It's available on this website. I would promote it because I think it's simple, practical enough to use in a busy practice setting. But there are plenty of other tools out there, and really the choice depends on your practice setting and how elaborate you want your tools to be. The opiate risk tool is very useful because it's simple. It's just 5 questions with 9 possible answers, comes up with a score, and is helpful because patients don't seem to mind completing it, and because it has this difficult question in there about a history of pre-adolescent sexual abuse, which is a very hard question to ask people, but once they've answered the questionnaire, it's a useful entree into the conversation. When you work in a chronic pain clinic, you realize that some sort of childhood abuse or even adult abuse is so often what is lying under the development of chronic pain that it really is worth exploring because it can be improved. This is just a simple PTSD screen, another thing that can be improved sometimes with the help of medication. PHQ-4 is very simple. You can use it by itself as a tool. The brief pain inventory is a little bit more elaborate, but it does contain very useful elements. This is the PEG. It's becoming very popular because it's simple and because it focuses on pain interference. And this is the PROMIS pain interference items that was developed by the National Institute Institute of Health to try and get some uniformity in the way people are measuring pain and pain outcomes, so that data can eventually be combined and we can look at pain and pain treatments on a population basis. This is the Department of Defense and Veterans Administration pain questions. Again, it's simple. The choice is really up to you. I'm sure you have Canadian tools as well, but in a practical sense, they need to be simple because otherwise they don't really fit into busy practice settings. So we'll talk a bit about the role of opioids. Let's say that opioids are powerful drugs and they really should be reserved for serious pain. Well, that's easy to say, but what is serious pain? I'd say that it's pain that has a clear pathoanatomic or disease basis. It's pain where the underlying cause is disabling. That is, it can't be improved by primary disease treatment or by lifestyle changes. It's pain that has a goal of treatment that is comfort, as in palliation. It's pain where all other treatments are not really possible. So, for example, the elderly may not be able to exercise the way younger people can, may not be able to take non-steroidal simple analgesics because they're very sensitive to non-steroidals. And they're also at very low risk of developing control issues. And small doses of opiates can be useful in that population. But 90% of pain that's currently treated with opiates don't meet any of these criteria. So I would propose that a lot of pain that's currently treated with opiates just should not be treated with opiates at all because they haven't been found to be helpful. I like to show this slide because I think these are the three most common pain conditions that do very badly with opiates. Axial low back pain that doesn't have a pathoanatomic diagnosis is very common. It's one of the most common complaints that's taken to primary care. And unfortunately now it's one of the most common complaints treated with opiates. Exercise and activity and healthy lifestyle are all far more successful treatments for chronic low back pain. Fibromyalgia does disastrously badly with opiates. Again, fibromyalgia responds much better to exercise and active lifestyle. And there's an additional factor with fibromyalgia, and that is that it's a hyperalgesic state. And opiates, particularly at high doses, make that hyperalgesia worse, not better. So in the case of fibromyalgia, one of the reasons not to use opiates is that with prolonged treatment, they can actually make fibromyalgia worse. And there are very few experts who disagree with that these days. Headache, we've known for a long time, does badly with opiates, particularly because of rebound headaches. Opiates never solve headache problems, ultimately. With all conditions, obviously, short-term treatment feels wonderful, and it's very easy to get sucked into because it does seem in the short term to be the only answer. But these common pain conditions really don't do well with chronic opioid therapy. So the principles of chronic opioid therapy, first of all, the most difficult decision is the decision at the beginning of treatment. And that is the patient a suitable candidate for opiates? Well, for any treatment, we do risk-benefit analysis. For opiates, that risk-benefit analysis is really tough. I would say on the benefit side, it has to be intractable pain-producing disease, that treating the symptom of pain is reasonable because no other approach is going to make a difference. The goal is therefore comfort in those cases. but it always has to be balanced against risk. So high risk of treatment failure, so not just development of addiction or dependence, but just treatment failure. That is, what I say treatment failure is the patient who takes higher and higher doses of opiates, but no dose is ever enough. So people at risk are people with substance abuse histories, including smoking, people with a family history of substance abuse, people with childhood sexual abuse, post-traumatic stress disorder, anxiety, depression, other mental health diagnoses, and young age. Young people are much more likely to develop problem use with opiates than older people. When you have intractable pain-producing disease and the goal is comfort, just as you would with palliative care, you may accept a greater degree of risk. When you don't, I personally don't think any risk is worth taking, because we're very bad at predicting who is going to get into trouble with opiates and who is not. You have to expect opiate treatment to be time-consuming and resource-heavy. The only way to do it well is to do it very carefully. One of the things we've done wrong is use opiates as a quick exit to the office. Doctors are very busy. They have 15 minutes with each patient. Patients in pain are very disturbing. We want to help them. It's very hard for us, given the way we train, to let patients leave the office without some sort of solution. And writing a prescription is often the quickest and seemingly easiest solution, but it really isn't an easy solution. If opiates are used, it should be done extremely carefully and will take a lot of effort. First of all, when you start chronic opioid treatment, when acute treatment seems to be becoming chronic opioid treatment, you need to have the conversation with the patient so that the patient truly understands the risk and benefits. A care agreement can be useful because some of the information can be written down and they can study it in their own time, but it's not a substitute for the conversation that explains the risks and benefits. Using a single prescriber and single pharmacy is good practice because it allows you to keep better monitoring of exactly what behaviors are developing. Picking up prescriptions regularly is also good practice, gets you to be able to see the patient rather than just sending in prescriptions. It's amazing how many prescriptions are actually sent from email requests and faxed to pharmacists, even though it's not strictly supposed to happen, at least not in the States. You need to continuously monitor both pain and function, psychological status. If you've got prescription monitoring, always use it. Recent guidelines have suggested that you should always use prescription monitoring with the first prescription, and thereafter it depends on how easy it is to actually use your system, but every prescription would not be a bad thing. And doing urine drug screens is also recommended, at least at the beginning of treatment and annually thereafter. And continue counseling. Chronic pain patients need a lot of help. It's very hard to live with chronic pain, and the counseling that they get from their clinicians is a very valuable component of the treatment that you can offer them. So in conclusion, opioids do not have proven efficacy and safety for treating pain, so we need to reevaluate our use of opiates for chronic pain. They're powerful drugs and they should be reserved for serious pain. Chronic pain is never simple, and so it should be approached holistically. Measurement-based care is the gold standard, and chronic opioid therapy is not a simple solution. If you're going to use it, expect it to be time and resource heavy. Thank you.
All right. Thank you very much, Jane. Let's see what questions we've got here. There was someone asking about, let's see. There was some curiosity. I think you addressed this to some extent in your second half of your presentation, but the ways in which opioids worsen function and quality of life, was that mostly, were you talking about the side effects that are often an issue with opioids?
Yes, a lot of the really bad adverse outcomes arise with high doses. But when someone takes opiates continuously, and when I say continuously, I'm thinking of people who take opiates round the clock. So they have always got opiate in the system. They tend to develop dependence. In fact, it's inevitable. They will develop dependence and they will develop tolerance. And so they will dose escalate, and you'll begin to see, not only this state of affairs where no dose is enough, so they're actually miserable because they never really feel they're getting good pain relief. Opiates are deactivating, so there's a tendency not to do all the things that actually improve health and lifestyle changes that improve health, particularly being active and returning to work and enjoying life, being able to enjoy things that they enjoy. And if they develop difficulty controlling use, that's miserable. I mean, it's a miserable state. So, those are reasons that continued treatment really makes function worse. But the most successful opiate treatment, actually, so if you look at studies, about 1 in 7 patients do okay on opiates. That's not very much, but it sort of confirms the idea that most pain that's treated with opiate, the opiate isn't improving the pain or the function or the quality of life. But the 1 in 7 tend to be people who take small to moderate doses of opiates intermittently. So they're not taking them continuously. They're not taking them round the clock. They're not taking long-acting opiates. They're taking occasional short-acting opiates, or maybe even daily. There are patients who may take a small dose of opiate to help them get up in the morning, like the older patient who takes 1 tablet a day, or the patient who has periods where they can manage perfectly well without opiates, but then something happens and they use opiates for a few days to get them through a bad patch, and then they stop because they don't have any difficulty controlling use. They don't want to use opiates too much. Then it's successful. One of the problems is predicting which patients are which, but as I said, the older patients with no history of problematic use and with not many alternatives available tend to be the class of patients that do okay with low dose opiates taken intermittently.
Out of curiosity, is that something, after you've done the assessment and you decide to prescribe opiates to somebody, is that something that can be somewhat controlled in how much is prescribed and how often?
Yes. I mean, if you look at the CDC guideline, the dosing guidance is much lower than any previous guidelines. That's one thing that makes the CDC guideline different. So in Washington State, we have a law that restricts the dose to 120 morphine equivalent dose per day. So any practitioner prescribing more than that has to get a pain consultation for their patient, or they have to document that the opiate treatment is actually improving function and quality of life, or they have to get a written evaluation done, so a chart review by an expert. But over time, that dose limitation has gone down. So the CDC guideline is now saying 50. A 50 is 2 Percocet 3 times a day, or 2 Vicodin 3 times a day. That's the sort of dose that has been found to be effective, not the whopping doses that people have been using, the 250 milligrams a day. When I first started practice, I often saw patients taking more than 1 gram of morphine equivalents a day. You don't see that anymore because it really wasn't good treatment.
All right, I think that's a very helpful clarification too. Let's see, somebody was wondering if you are familiar with the pain catastrophizing scale or the Tampa, I'm probably going to say this wrong, kinesiaphobia scale?
Well, yes, but actually we don't use them very much in our clinic, because even in a pain clinic setting, it's a practical issue of how elaborate your measurements are. But I think I think pain catastrophizing is very important. Maybe we should use them.
All right, and then someone else wondering, what are your thoughts on increasing use of marijuana, medical or not, in addressing chronic pain?
Well, I personally think that if people find it helpful, I mean, patients often tell me they're taking marijuana and ask me if I mind, and I say I don't mind, because I think if it's helpful, it's a lot safer than opiates. In Washington State, it's legal to both recreational and medical use, but it's not legal stateswide. On a federal basis, it's illegal, so it's a little bit difficult. But medically, we don't have that much evidence that it is a good analgesic, but it certainly helps people get through painful experiences. So I don't discourage it.
All right. And then someone wondering if you know of gender differences in the efficacy of long-term opioid use for chronic pain.
Well, there are certainly gender differences in the amount that's prescribed, and there are gender differences in the development of problematic use. But it depends on the population, and it depends on the age group. So the middle-aged, 35 to 45, I think it is, males are more likely to get into trouble with opiates than females. But younger females have a higher incidence of chronic pain, a higher use of opiates than males.
All right. Someone wondering what kind of health providers fit within, when you were discussing the new pathway versus the old pathway, within the holistic approach. Would it be chiro, acupuncture, massage, meditation?
Well, I think if you have those things available, it's really helpful, and it depends on the setting. Often for American patients, they have to find those resources on their own because they're not present in our clinics. But I mean, in our clinic, we have an integrative medicine specialist who does a lot of complementary approaches, not actually acupuncture, but she does intramuscular needle treatments and nutritional counseling and lifestyle counseling, and that's useful. Every clinic has different resources available, but I would certainly include all those things, either that the clinic provides itself or that patients can find on their own. But the bottom line is, encouraging people to do all these things for themselves, and also using books and websites and apps. They can be very useful. Behavioral treatments, once they're in place, once someone's trained to do, for example, cognitive behavioral approaches or biofeedback, there are a lot of apps that can help them continue it, to practice on their own.
All right, and there's a patient wondering if you had any advice about how, as a patient, to address this kind of a conversation with your physician around opioids and around treatment, not based on just on the pain scale.
Well, I think, the really important thing for patients, the conversation that patients have with their providers, is what their personal goals are, and, what they want out of treatment, and what they've understood from their own. This is an era where anybody can become informed about their own condition or the treatments that are available, and what their personal choices are. And I mean, I don't know, I'm given to understand there are some physicians, there are still a few physicians who say, this is treatment that I can offer and that I strongly recommend, and give less choice. But on the whole, I think we are taught these days to discuss choices with patients and give them the autonomy to choose for themselves.
All right, and then someone asking, what kind of functional measures are most useful for decreasing reported pain intensity?
Well, functional measures will depend on, what the pathway is that the medical pathway the patient's been through. So, for example, if you've got a wrist problem, you probably would go through orthopedics or rehab medicine, and your grip strength will be measured. But the most important goal really is the stated goal at the beginning of treatment. So on a much broader level, when you start treatment and establish the goals of treatment, it could be anything between, for someone who's got a really serious problem, it may be that their goal is to be able to sit with their family for an hour, or sit up at the table for an hour. Or someone else, it may be their functional goal is to get back to work, or someone else, their chief functional goal is to be able to play with their grandchildren. And so keeping in mind the stated goal, functional goal, and measuring to that goal is probably the most helpful thing. Or focusing on what the particular condition is would be reasonable functional goals. I mean, I think the question is, can you improve pain intensity with functional improvement rather than functional goals? Certainly, if you go through a rehab program and become stronger, for example, if you have low back pain and you can improve core strength and improve activity, and maybe get swimming or walking, or just in general being more active, or being more occupied, that the pain intensity will actually improve just because of that functional improvement, for no other reason than that you've achieved some functional improvement and the pain will improve.
All right. And on a similar note, someone was also wondering if they can get comments on they were also asking about functional measures you recommend, but wondering if you could comment on CMOP and or AMPS, which I don't actually know what either of those are, but
CMOP, I don't know. Oh, no, I don't. Sorry, I don't know.
Okay, then.
I'm not very good with acronyms.
Maybe I'll see if that person would mind just typing out the full name of those functional things. We'll move on to another question for the moment. Oh, wait, they did. Canadian Measure of Occupational Performance and the Assessment of Motor and Process Skills. Have you heard of either of those tools?
I think I've heard of the Canadian Measure of Occupational Performance. But as I said, the measures you use will depend on the practice setting. So this is that would be a measure that you would use in occupational health, I assume. And if you go into rehab, you would do a lot of strength measurements. You go to physical therapists, they measure strength and they measure the mobility, and they're all functional measures that are practice specific.
Right.
For me, because I'm I'm addressing it from a much broader perspective. My functional goals are what the patient wants to achieve and have they achieved what they want to achieve. That's a reasonable functional measure. Quality of life, there are lots of scales you can use to measure quality of life. And I think actually quality of life is the bottom line. If the treatment isn't improving someone's life, then it's not successful. And sometimes opiates make people's lives worse.
Right.
Much worse.
Okay. And there was someone asking that you mentioned, in addition, like you did recommend patients getting counseling from a therapist, but you also mentioned that counseling from the health provider is an important factor in pain management. And someone was wondering if you had particular strategies when you mentioned that, like CBT or motivational interviewing or something that can be done by the health professional on that level.
Well, I think it's part of, what I wish I'd been taught and what I hope we teach the next generation of physicians, that, an important part of pain management, chronic pain, particularly chronic pain management, is mentoring patients to take an active role themselves and not just handing out passive treatments or not allowing them to be passive. And that actually takes a lot of skill to do that. It's something I think we should all be learning to do, is just engage patients in, in the process of getting better themselves and not just expecting us to come up with, a miracle treatment that's going to make all the difference, because apart from anything else, we just don't have those miracle treatments that make all the difference. We can make more difference by encouraging patients to just do the right thing. And cognitive behavioral therapies, I think you need to be trained to do that. So that's where you use a psychologist to do the counseling. But I'm talking about, not just the counseling that trained counselors do, but the counseling that any provider who's dealing with chronic pain, and that certainly means any primary care physician, because a lot of what they deal with is chronic pain. And they hate it, incidentally. They just dread it because we've got in such a mess with false promises and failed treatments, and this idea that we have to come up with solutions rather than empowering patients to come up with solutions themselves. So that's what I mean by counseling.
All right. And then there was a question about the role of neuroplasticity in reducing persistent pain. Just wondering your thoughts on that.
Well, we do know that the experience of pain can be profoundly altered by the state of mind, or what we think about pain, or how we process pain. When we know that, as I said, two different people can have exactly the same pathology and have a completely different pain experience. And that's because they process it differently. And pain is not a bottom-up phenomenon. It's a top-down phenomenon. So all the descending pathways, all the processes that go on with the emotional aspects of pain are terribly important in altering what the pain experience is. That's why catastrophizing and acceptance and coping, all those skills, learning to beat catastrophizing, or learning acceptance, or learning coping strategies, make more difference to chronic pain than any medication, because they alter the way that pain is processed. So that is a terribly important aspect of what we can do to help people with chronic pain.
Wonderful. I think that's a really good point, and it's a good place to end is knowing that the goal is function, improving function, but also changing the way that we think about chronic pain and about chronic pain treatment, both as patients as well as healthcare providers. I think that's great. Thank you very much, Jane, for the presentation. We are a little bit past our ending time, so I do want to go ahead and wrap it up. But thank you very much for the presentation and for sharing your insight and your experience with us.
You're very welcome.